Welcome to the Medical Nursing Podcast, the go-to show for vet nurses and technicians passionate about internal medicine. I'm Laura Jones, a registered vet nurse, all-around medical nursing nerd, and your guide to breaking down complex medical diseases into simple, actionable chunks. Each episode is packed with knowledge and tips that you can start using right away to give even better patient care. So let's get started. Hello, and welcome back to the podcast, or a very, very warm welcome if this is your first time listening. You are listening to episode 118 of the Medical Nursing Podcast, where we are currently midway through our GI disease revisited series. We have looked a lot at what's changed across the past few years, and today we're looking at another commonly misunderstood GI condition, and that's acute haemorrhagic diarrhea syndrome, or what we previously knew as haemorrhagic gastroenteritis, or HGE. Acute haemorrhagic diarrhea syndrome, or AHDS, is one of those conditions that arrives as a real emergency. Often we've got a really flat dog with severe GI signs, passing what's basically frank blood. And if you are picturing the smell right now as I explain this, then please know that I am too, and it's making me feel probably just as sick as you do right now. So we know these patients are really severely affected, and the care that they need from us as veterinary nurses and technicians, especially in the really early stages of them coming into us, makes a massive difference to their outcome. It's also a condition where the evidence has really changed how we approach it. So when I was in practice in earlier years, I just thought that HGE wasn't really that big of a deal, except for maybe the smell. The patients that I saw with it seemed to mostly be stable. They had some fluids, some antibiotics, some supportive care. We tempted them to eat, and they went home anywhere between, 2 and 3 days later in the vast majority of cases. But for me, as I spent more time working in referral settings and emergency settings, I saw just how bad they could be. And also alongside this, just how much the way that we treat them and, for me, nurse them has evolved. In recent years, we have changed the name of this condition, we've also changed our understanding of what causes it, and we've changed how we treat it, especially when it comes to things like antibiotics. And all of this means that the way that we approach these patients as veterinary nurses also needs to change as well. And in this episode of the podcast, that is exactly what we are going to be looking at. We will be looking at what AHDS is, what causes it, and of course how we can use more of our skills when supporting these patients. So let's waste no time and get started, and we're going to start by looking at what actually AHDS is and the way it impacts our patients. So acute haemorrhagic diarrhea syndrome, or AHDS, is defined as a sudden onset of severe, bloody and watery diarrhea. It's accompanied by significant fluid losses because what happens is fluid actually shifts into the intestinal lumen, and it's often preceded by vomiting. So the vomiting at home might be the initial sign that the caregiver notices, and then it progresses to that severe diarrhea. Now, the fluid losses that we see with AHDS are often more significant than they might initially seem, and this is really, really important for us to understand. And the reason for this is because these patients don't necessarily have massive outward fluid losses. They certainly can have really profuse large volumes of diarrhea, but actually much of the fluid that these patients are losing, those changes are actually inside the body, meaning that we can't necessarily see or accurately measure just how much fluid our patient is losing. So what happens with these patients is they will shift fluid into the intestine. So actually they can be significantly dehydrated and even hypovolemic, even if they are not actively passing huge volumes of diarrhea at that moment in time. These fluid shifts can actually happen really rapidly. So I actually had an AHDS patient not so long ago, and I was called to have a look at them in wards, and they went from looking pretty stable to showing quite significant signs of hypovolemia over just a couple of hours. So I was called back to check on them mid-morning, having looked at them sort of first thing in the morning after my shift started, and I found that they were progressively lethargic compared to when I had last seen them, and when I assessed them they were tachycardic and had bounding pulses, even though I had not observed that on my morning assessment. So the check I had done just a couple of hours before that was normal. So it really shows how quickly their disease can progress and actually how dynamic fluid imbalance is in the body. The bloody diarrhoea is what we all tend to notice more because it's there, it's obvious, it's quite scary and dramatic, especially when it's that horrible red colour and it's outwardly obvious. But the fluid inside the gut is often causing a far bigger problem for the patient, and that fluid level in the gut can change rapidly. For years, this condition was called haemorrhagic gastroenteritis, or HGE. And you, like me, will probably occasionally still hear it referred to as that, even though that name is a little misleading. The problem with that name is the G, the gastro bit of gastroenteritis, because we used to believe that this was a disease of the stomach and the intestine. And if we think about it, these patients present with vomiting and then diarrhoea. So if we take the clinical signs at face value, that name kind of makes sense. But interestingly, the stomach is not the problem. In fact, one study showed that dogs with AHDS have a completely normal stomach on endoscopy and biopsies, even though the dogs in that study were actively vomiting blood. However, because obviously they scoped these patients, they also looked at the small and large intestine, and they did absolutely not look normal. They had severe necrotizing and bloody damage throughout the small intestine and the large intestine, with the colon actually being the worst affected area. So acute hemorrhagic diarrhea syndrome as a name far better describes what's really happening within the GI tract in our patients. And I know that I have gone on about terminology a lot in the last few episodes, and you might think I'm being pedantic, but this change actually really matters. Because if I was to say to you gastroenteritis, the treatment that might immediately jump to mind is going to be things like vomiting management, antacids, maybe gastroprotectants. And in reality, things like gastroprotectants and antacids in particular can actually make things worse for patients with AHDS. For example, by impacting the microbiome, as we mentioned in last week's episode 117. If we then look at what causes AHDS, for a long time we actually thought that this disease was idiopathic, so we didn't know what the specific underlying cause was. But now we have more evidence, and with this we have a better idea of the causative agents involved. And actually, AHDS is thought to be caused by a bacterial toxin called NET-F. It originates from a particular strain of a bacteria called Clostridium perfringens, which is the strain type A. Now, if you listened to last week's episode on the microbiome, episode 117, you'll already know that C. perfringens is a normal resident of the GI tract. It is part of the microbiome. It lives quite happily in loads of our healthy patients, causing absolutely no trouble at all. However, in AHDS, there are certain strains of it that overgrow and become pathogenic. And these particular strains carry the gene for that toxin called NET-F. Now, NET-F is known as a pore-forming toxin, and pore-forming pretty much does exactly what it sounds like. So the toxin causes pores to form in the enterocytes, in the cells lining the intestine. What it basically does is it punches holes in the cell membrane of those cells, and this means that the cells can't hold themselves together normally. So water rushes into them, the cells burst, and if we kind of multiply that by the widespread area across the GI tract where this is happening, what we end up with is significant amounts of intestinal lining basically dying off. And that intestinal necrosis, along with the huge shifting of fluid into the gut that we see with AHDS, is what causes that marked hemorrhagic diarrhoea that we classically see in these patients. What's really interesting though is that toxin, the NET-F toxin, actually clears itself from the system really quickly. So within about 7 days of the dog presenting with clinical signs, the NET-F levels will drop below the level that PCR tests can detect. And that happens regardless of whether it's treated or not. And this is important to remember because if the toxin that causes the disease is self-limiting and it clears regardless of treatment, antibiotics, even though it is a toxin from a bacteria that's causing this, are not going to be indicated in the vast majority of these patients. Another interesting point as well, and one that I actually think that we get wrong quite often, is that AHDS is not contagious. So technically, we don't actually need to barrier nurse or isolate these patients. That being said, to begin with at least, we can't be sure that the patient truly has GI signs due to AHDS. We need to rule out other causes of diarrhoea, and actually AHDS is diagnosed by exclusion. So until things like parvo, giardia and other infectious causes have been ruled out, we will need to barrier nurse these patients as a precaution. Also, sometimes, albeit rarely compared to other causes of diarrhoea, these patients can end up neutropenic, so where they have low white cell levels and they become immunocompromised and at an increased risk of infection as a result. So if your patient is neutropenic because of their GI disease, they will need to be barrier nursed for their own protection, so reverse barrier nursing in this case. So it all depends on the individual patient, but at face value, AHDS alone, if we're 100% sure that that's what it is, does not actually need to be isolated or barrier nursed. Okay, so that's what AHDS is and also what causes it. But if we move on now and look at which patients get it and the clinical signs that we present with, the evidence is also interesting. Because we typically see AHDS in young or middle-aged breeds, typically small or toy breed dogs. But interestingly, one study did find that Labradors were actually the most common breed presenting with the condition. So we do also see this in our larger breed patients too. AHDS also seems to be more prevalent in the winter, with suggestions that cold weather and even eating snow could be associated with developing the condition. And diet changes or scavenging does not seem to be associated with it, which goes against what many of us, myself included, thought for a very long time. Lots of time with HGE, we think, oh, the patient must have got into something. That doesn't seem to be the case. Looking at clinical signs, these patients typically present with an initial history of vomiting, as we mentioned, followed by that profuse, watery, bloody diarrhoea, which is often a bit mucoid because it's often large intestinal, and it's typically described as having a raspberry jam type appearance or consistency. Alongside this, patients will be lethargic, they will have varying appetite changes, typically they will be anorexic, and they will have significant fluid balance disruption, as we said, even in the absence of external fluid losses. As I touched on before, the fluid changes can happen so quickly in these patients that the external signs of dehydration, so prolonged skin tint, dry mucous membranes, etc., have not actually had the chance to keep up with the speed at that fluid balance change. So this means that for us, rather than focusing solely on the so-called kind of traditional signs of dehydration, perfusion is what we need to prioritise in these patients. So this means checking things like heart rate, pulse quality, mucous membrane colour and capillary refill time, alongside things like mentation and maybe even blood pressure. We also need to be looking for things like tachycardia and bounding pulses. So these tend to indicate compensatory hypovolemic shock, and this is usually the early change that we will see in these patients on examination. Also, interestingly, these patients are typically not pyrexic. Their temperature is actually normal or slightly low in the majority of cases. So if you are seeing pyrexia in a patient, this should be raising concerns for things like sepsis. This episode is brought to you by the Veterinary Internal Medicine Nursing On Demand Library Club, and honestly, if you are not already a member, then you're going to want to hear this. For just £21 a month, you get access to the entire Veterinary Internal Medicine Nursing webinar library. That is over 60 hours of CPD, and it's growing month on month on all things internal medicine nursing, and it's available on demand whenever you need it. And it doesn't stop there. Every single month you get a brand new webinar too, plus access to the monthly evidence files live sessions all included. Whether you want to deep dive into a specific topic or just keep your CPD ticking along, the Library Club makes it ridiculously easy for you to do so. There's no contract, you can cancel anytime, and if your clinic gives you a CPD budget, I can even invoice them directly for a yearly subscription. Think of it as your own personal library card for veterinary nursing education. Head to veterinaryinternalmedicinenursing.com and check out the Library Club to grab yours. The link is waiting for you in the show notes. And now, back to the episode. Looking at diagnosis, AHDS is diagnosed by exclusion. This means that we need to rule out other things that mimic it while assessing the patient's overall health, and also using things like their blood results to guide treatment and stabilisation. Common diagnostics include PCV and total solids, alongside venous blood gas analysis, routine blood work, so biochemistry, haematology, and potentially also GI imaging, so things like abdominal ultrasound. Looking at common results, we often will see a relative increase in PCV in these patients, and we see this because lots of fluid moves from the intravascular space into the gut. This increased PCV will actually sit in the face of a normal or even low, often low actually, total solids, because what happens is that gut wall is so diseased that protein will leak through it, causing protein loss. And if we think about PCV total solids changes that we would see in a traditionally dehydrated patient, we would expect both PCV and total solids to be high. But we don't see that with AHDS, so a low total solids and a high PCV is a clue in these patients. We'll also use our diagnostics to exclude things like parvovirus, parasitic disease, Addison's disease, GI foreign bodies, and other causes of diarrhoea before the vet arrives at a diagnosis of acute haemorrhagic diarrhea syndrome and then begins to think about treatment. Speaking of that treatment, these patients often require intensive treatment and supportive care, but usually for quite short periods of time in hospital. In fact, if we catch AHDS early and treat it properly, most dogs will recover within between 1 and 3 days, and low mortality rates of less than 10% are reported, assuming appropriate and prompt hospitalisation and treatment. And if we look at that treatment, the most important area of treatment is actually fluid therapy. These patients need, as we've said, often intensive fluid support with a balanced crystalloid solution such as Hartmann's. We need to resuscitate any hypovolemia that's present first using appropriate crystalloid boluses under veterinary direction, and then after this we need to move on to rehydration. So assessing percentage dehydration in these patients, which we know can be challenging because their fluid losses may not be obvious initially, and then using that to create a rehydration plan. And then after we've rehydrated them, we need to consider alongside this maintenance and ongoing losses. And these ongoing losses, and I know I've said this a lot, may not be as obvious as they initially seem because much of that loss is happening in the patient rather than externally. So yes, we need to quantify things like the production of diarrhoea. Fecal catheters, for example, in these patients are fantastic. If you can't place one of those, making sure we're weighing the bedding and things like that. Or as far as possible, when we're walking these patients, trying to quantify the amount of diarrhoea that they have produced. So yes, we absolutely need to be quantifying all of that, but this is also a great argument for things like serial point of care ultrasound, looking at things like how dilated the intestines are with fluid-filled content. And this is an area that we are ideally placed to monitor as veterinary nurses. We can grab the scanner, we can have a look at the intestines and see how fluid-filled do they appear, and then take that information to our vets. Also, weighing these patients regularly is really, really important because acute weight changes are typically associated with fluid balance rather than things like nutritional status. So for these guys, we will be often weighing them as often as every 6 hours. Alongside traditional fluid therapy, we need to consider electrolyte supplementation. So hypokalemia, for example, is common in these patients, especially if we've got a mixture of anorexia and GI losses. And electrolytes will need to be regularly monitored and then supplemented as needed. Also, hypoproteinemia is common in these patients because, as we said, the diseased gut will start to leak protein through it. And where hypoalbuminemia, so low albumin levels, are present, we will also see further shifts in fluid balance. So we can see things like edema and third spacing of fluid into body cavities due to a loss in colloidal oncotic pressure. Alongside fluid therapy, supportive care is the next biggest part of treatment. These patients will often need antiemetics, anti-nausea medication, analgesia, etc. as needed based on the individual and your assessment of things like their pain level, ongoing vomiting and signs of nausea. Perhaps more importantly than what we do use in these patients is actually what we do not use. So antacids, as we've mentioned, like omeprazole, and also antibiotics should not routinely be used in patients with acute haemorrhagic diarrhea syndrome. The reason for this is we don't have enough evidence to say that they have a benefit, and we actually know that both antibiotics and antacids cause significant disruption to the microbiome. And in the case of antibiotics, this can actually persist long past the patient's diarrhea resolving. Multiple studies, which I have included within the references in the show notes if you want to read them, have all investigated the use of antibiotics in these patients without significant overwhelming benefit. Interestingly, in most cases, the liver will actually mop up any translocated bacteria. So even if we think that we've got bacterial translocation, so movement of bacteria from the gut into the body across that diseased GI wall, in some cases antibiotics will not be needed because if the liver is functioning normally, it can actually kind of defend against those bacteria and sort the problem out itself. That being said, if a patient is not improving on supportive treatment and fluid therapy, or if there's evidence of sepsis or concerns for sepsis or systemic infection, then of course antibiotic use will be indicated. So there are actually guidelines that say when we should be using antibiotics in patients with acute diarrhea, and the recommendation is to reserve them for patients where sepsis is a concern, where they are not responding to initial first-line treatment, or if they have a banned neutrophilia, neutropenia, or immunocompromise. And yes, I know it's going to be our vets making these prescribing decisions, but it's still really important for us as veterinary nurses and technicians to be aware of kind of the pitfalls and common kind of misconceptions around antibiotics and when they should and should not be used. Also, I want to talk about nutrition because just like most other GI diseases and actually most other diseases in general, early nutrition is absolutely vital. And we all know nutrition is an area that we are ideally placed to manage as veterinary nurses and technicians. We want to get food into that gut as early as we possibly can, so as soon as the GI tract will cope with it. And we want to do this using a highly digestible diet because that is a diet where it's as easy as possible for the guts to get all of the nutrition out of that food and to break it down and digest easily. By feeding the gut, we're actually helping the GI lining heal. We are feeding the enterocytes, so the cells lining the gut, because they get their nutrition directly from the food that's passing over them. And with this, we will support the GI barrier and also feed the microbiome as well. If the patient will not eat sufficient volumes voluntarily, which most of them won't, especially in the first couple of days, then placing something like a nasogastric tube is a fantastic option for these patients, assuming, of course, that the vet agrees that this is okay and that the patient's vomiting is appropriately controlled. And then alongside creating that feeding plan, placing that tube and administering enteral nutrition, regular tempting the patient to eat by mouth, calculating and quantifying caloric intake, and regular repeat nutritional assessment are all vital parts of our role as RVNs looking after these patients in practice. We tend to focus a lot on AHDS in the hospital, but actually we also want to look at what happens to these patients long term, because we now know that AHDS has a far bigger impact on our patients than just during their period of hospitalisation. We usually think that AHDS is quite a scary few days of often very intensive care, and then a quick recovery, or hopefully a quick recovery. And on the face of it, that's what it looks like, because typically these dogs recover quickly, they go home, their signs improve. But actually, with the benefit of evidence, we now know that many of these patients will go on to develop chronic GI signs in later life. So studies have shown that around 30% of patients with AHDS will have recurrent GI signs in the future, compared to 14% of matched control dogs. So this means that our patients with acute haemorrhagic diarrhea syndrome have twice the risk for chronic enteropathy in the future compared to dogs without it. The theory behind why this happens is that the gut barrier damage that happens during that acute period of disease allows things like proteins from food to cross the GI tract, where they are then exposed to the patient's immune system. This is thought to impact the dog's tolerance to their own food because the immune system can become sensitised and you end up with a chronic food-responsive enteropathy as a result in the future. And also the dysbiosis that we see in AHDS almost certainly feeds into this as well, because we know that this disease can cause lasting changes to the microbiome. For me, this is another reason why it's so important to use antibiotics appropriately in these patients, because they can cause further changes to the microbiome, often for significantly long periods, which could increase the risk of further disease in the future. So I want to finish up in the way that I always do, which is looking at how we as veterinary nurses and technicians can use more of our skills to support patients with AHDS. And this is important because we know that this is a disease that asks a lot of us. These patients might only be with us for a few days, and hopefully that is the case, but when they are in the hospital, they need intensive nursing care and monitoring. And with this, of course, there are lots of ways that we can use our skills. From triage and stabilisation to initial diagnostics, careful monitoring, regular reassessment of fluid balance, alerting the vet if anything changes, nutritional planning, support, antimicrobial stewardship, I could go on. All of this means that our knowledge and skills make a real difference in the care of these patients. And this care persists after hospitalisation as well. We need to be talking to our caregivers about things like at-home nutrition, monitoring, when to come back and see us, and that initial kind of at-home recovery period. And we can also continue this support remotely in the days following discharge as well. So let's recap what we have learned about acute haemorrhagic diarrhea syndrome and also our role in caring for these patients. AHDS is far more than just HGE. It is an acute onset condition causing severe changes to the small and large intestine, but leaving the stomach mostly unharmed. It's characterised by severe intestinal wall necrosis due to an overgrowth of that Clostridium perfringens type A bacteria, and more specifically its NET-F toxin, which is the toxin that goes around kind of punching the holes in those cells and causing that intestinal necrosis. Regardless of treatment, that toxin clears within about a week, and this explains why we see an intensive but short duration of disease, and also why we routinely avoid antibiotics, because that bacterial toxin will clear on its own. Looking at treatment, fluid balance is everything in these patients, even in the absence of outward losses. We know that these patients can dump a ton of fluid into their intestines and go from stable to hypovolemic in a matter of hours. And it's careful nursing, monitoring and intervention that allows us to spot this and correct it quickly. And alongside this, we need to prioritise early enteral nutrition, restoring nutrition back to the gut, healing that intestinal lining, and of course, with this, providing intensive supportive care. And as always, we are ideally placed to help with every single bit of this as veterinary nurses and technicians, from initial triage all the way through to discharge and beyond. So that is everything that I have for you this week on our deep dive overview of acute haemorrhagic diarrhea syndrome and what we have got wrong about what we used to know as HGE up until recently. I hope that this has been helpful and has given you some new ways to think of how we can support these really common patients that we see in practice, all of us, on a regular basis, and also some ways that you can use more of your skills when looking after these patients. As always, if you found the episode helpful, please do follow the show, make sure you're subscribed on your podcast player and share it with someone else who will find it useful. Please consider leaving a rating and review. I appreciate it so much. It really helps me grow the podcast and help more nurses and technicians help their patients even more. Thank you so much for being here and learning with me. As always, I appreciate it more than you know, and I can't wait to speak to you in the next episode. Bye. If you've made it this far, then thank you so much for listening all the way to the end of the episode. And I have one more thing to ask of you before you go today. I would love to hear from you. Yes, you. I love hearing about the cases that you're seeing, the skills that you're using, and the conditions that you want to learn more about. Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing, and don't be shy. Come on over, say hello, and tell me a bit more about you. Talk to you soon.